Good afternoon, everybody, and welcome to this afternoon's session on effective board committees. I'm Miriam Deakin, I'm Director of Policy and Strategy at NHS Providers, and I'm looking forward to chairing this afternoon's conversation. So warm welcome to our two panellists this afternoon, who are going to share with us in a few moments two different approaches to getting best value from committee structures. So warm welcome to Daniel Scheffer, who's Director of Corporate Affairs and Company Secretary at Liverpool University Hospitals NHS FT. And Daniel brings a wealth of experience from different trusts, particularly across the Northwest. So we'll have a lot to share with us. And warm welcome to Brian Stables, who's currently Chair of the Audit and Risk Committee at Avon and Wiltshire Mental Health Partnership, NHS Trust, but brings a broad range of experience from the private sector and the NHS, and was until recently Chair of Royal United Hospitals Bath at NHS FT. So just before I turn to our panellists to share their insights with us, just give you a rundown of the format and a little bit of housekeeping. As you know, all sessions are being recorded so that we can share the learning a little bit more broadly and put it onto our website. Because we're in a webinar format, if I could encourage you to put any questions for our panel into the Q&A app, which I understand is at the bottom of your screen. That would be fantastic. I'll keep an eye on that, and when we come to the Q&A section, I can read out your questions and direct them to the panel. So you can put a question in there at any time, so feel free to do that as you're listening to our spokespeople, and we can pick up those questions in the Q&A. So we'll hear from each of our speakers in turn, and then we should have plenty of time to unpack what they've shared with us, draw out any common themes in their different approaches, and ask any detailed technical, if you want to, questions of our two experts today. So without further ado, I'm going to turn first to Daniel, if that would be okay, to share your insights with us.
Thank you, Miriam, and thank you for inviting me to join this session. So I'm Daniel Scheffer, I'm Director of Corporate Affairs and Company Secretary at Liverpool University Hospitals. I joined the Trust just over a year ago, so I've been in place probably about 13, 14 months now. And as Miriam said, I've worked in a number of different organisations as a company secretary mainly across the Northwest. If we were in the room live, I would have sort of asked people a bit of an opening question, which was about what was the year that FTs were first established in the NHS. And I'm sure many of you would have shoved your hands up and told me it was 2004, which was correct, where the first 10 was first introduced. And I just want you to keep that date in mind when I come to a future slide. Just to give you a bit of context for Liverpool University Hospitals, it first became an FT technically in 2006 as part of the Aintree Hospital, and went forward as a merger in October 2019. And that was between the Royal Hospital and Aintree Hospitals. And so it's only been in existence since October 2019 and is still fairly new then, as it entered into that period and COVID started straight after. So next slide, please. So earlier in today's event in session 2, you heard about some of the changes to the Code of Governance that are going to be coming out very shortly. But in essence, I just wanted to remind people what's in the Code of Governance now between board level for decision making. And this won't come as a surprise to any of you in the room. What does corporate governance mean? It's a means in which board leads and directs their organisation so that decision making is effective and the right outcomes are delivered. It talks about the role of a unitary board and the role that all directors play, both executive and non-executive. And it talks very much about the importance of constructive challenge, board discussions based on the principles of priority, risk mitigation, value, standards and strategy. And then it also goes on to talk about the role of non-execs to scrutinise performance of management in meetings, about agreed goals and objectives, and then satisfy themselves about the financial information and also systems of risk management. So these are the things that have been with us since the Code of Governance were first introduced, since the FTs were first introduced, and I suppose make up what we should be seeing across all of our board and our corporate governance arrangements. So next slide. So I'll talk in a couple of slides about some of the changes that we made in Luft, but again, from moving on from that context, we had to make some serious changes within Luft as an organisation. Probably about 2 months after I started, we had a review of our governance arrangement, an external review by NHS England Improvement, and that was on its governance arrangements. But just before I started, and twice during 2021, we had CQC inspections across a number of our sites. This included a well-led inspection. And during the period of especially 2021 up until now, we've had multiple changes at executive and senior operational level. Last week, we've had our new chief executive start. He's my third chief executive since I've been in role. So that tells you about the number of changes that we've had. What's interesting, there's been stability within the non-exec team. Apart from one new appointment, it's been fairly stable for during that last 12 months. But basically, what the relevant inspections, CQC and the governance inspections told us were these weren't new problems. They were long-standing problems that the Trust knew about for a long time. They'd been through committees, they'd been on risk registers, but they haven't really been tackled. The big serious problems in terms of poor clinical and non-clinical practices were there when CQC had previously inspected and as part of the merger. We've had a number of never events reported. There was a lack of effective management and reporting systems, so they couldn't see a clear line of sight. Repeated incidents, basically saying lessons not being learned. The barriers to disclosure and investigation is more about the transparency that we should be seeing at all levels of the organisation and open reporting. And let's not forget the gift that keeps giving, which is COVID and the changes that we had to make in governance arrangements from COVID. But I don't want to use COVID as an excuse because I don't think it stopped us doing good governance. So next slide. So just going back to 2004, again, if I was in a room, I would probably ask you all the question, if anyone could tell me the best-selling mobile phone in 2004. I did test this out with some people, and you'll probably remember it was one of those old bricks. It was a Nokia 7020, which was the biggest selling. And what was important about that Nokia, it was the first Nokia that actually had a camera as part of the phone. And it's really interesting. So if you go back to 2004 and you look at what changes have there been to our corporate governance arrangements in the last 18 years and compare that to the changes that you would see in technology during that same period, they've moved on greatly because the NHS changed and adapted in that period of time. It's a bit of a provocative question, but when we looked at our governance arrangements, what we wanted to say is those governance arrangements that have been used across the board, have they actually stopped failures of governance? And did we need to have a bit of a radical rethink and look to what does the core governance say in the Code of Governance and what did the legislation say? So next slide. So when we looked at this and we looked at it across the board, we started with some overarching principles, as you would say. We wanted to make sure that there was improved line of sight and improved line of sight of the key issues. We talked about refocusing the role of the board, focusing on the key strategic risks and the risks to delivering our operating priorities, as well as looking at the strategic internal and external focus that they needed. We needed to provide clear clarity about leadership, and that was leadership at all levels of the organisation, right through from a ward through to a board. And we needed to strengthen the autonomy so that more decisions were made closer to the patient as possible. And finally, we counted up as part of our structure, we had something like 154 regular meetings that our senior leadership team were involved in, either on a monthly, bi-monthly or quarterly basis, which was basically tying them up in knots because they spent a disproportionate of their time in management meetings as opposed to being leaders within the organisation. Next slide. So as part of the NHS family, we are all part of the same flock, but that doesn't mean that we can't be different. And I suppose in Luft, the last 6 months, we've had an interim chief executive, and Sir David Dalton has been our interim chief exec, which has been a real eye-opener because David has challenged us to think differently and think about how do we remove some of the barriers and how do we instill good governance, but to think differently. So next slide. What we looked at was to basically strip out a number of our NED-led committees. So we've moved, we've got a board of directors as with everyone else, and that meets on a bi-monthly basis. And the top lines, we've still got our Council of Governors that meets on a quarterly basis. We've only technically got four NED-led committees. One is the standard, which is the Audit Committee. We've got a Nominations and Remuneration Committee that meets on an ad hoc basis, and charitable funds. For those of you who know history, we've got a new hospital committee, but hopefully when our new hospital opens very, very shortly after a number of years' delays, that committee will stop in hopefully 2 or 3 months' time. And what you'll see alongside that, we have an executive-led committee that reports through to the board, which is an executive assurance and risk committee that's chaired by our chief executive. Next slide. We do, though, however, many of the normal things that you would see in a governance arrangement that usually would be NED-led, these are now led by the executive directors, and they report through on a monthly basis to the Executive Assurance and Risk Committee. Basically, the way all of these groups work is to focus on the key risks that are registered on our risk register. So we moved away from the 5x5 model. We've now got a risk register that looks at likelihood, consequences, but also the strength of the controls that we've got in place. And these committees review every single risk that scores above 10 on that structure. So it's a 5+5+5 model. And what that means is, from a chief exec's point of view, he has clear line of sight of all of the major risks facing us as an organisation. And these are the ones that are discussed at every single meeting of the Audit Committee. Next slide. One of the key things, our NEDs were very nervous. And I think what's important to reflect is we probably introduced this a little bit too quickly. And if I was to go back, I would have given a bit more time for the NEDs to feel safe in the new structure. But our NEDs went with this. They trusted us to say our previous arrangement wasn't working. They were having too much discussion about the weeds and not looking at the bigger picture. But what they've now said is the wider membership, as you said, has given them a broader agenda. So the Audit Committee focuses very much on all risks within the organisations. It is, though, dependent on strong information systems. And so what I would say is not just your risk management, but also your performance management systems. It does rely, and so any governance system relies on openness and honesty of the execs to raise the risks. And it also needs you to think about how can NEDs triangulate the information that they're hearing in a different way. It is still very early. We're only in month 4 of the new arrangements. And what I would say is our board meeting last week felt like the first meeting of things working properly. So we've only just after 3 months, I think, started to hit a good cycle of reporting where board members feel more comfortable with the new arrangements. We're going to have an external well-led inspection later this year or early in 2023. But all in all, this new system is working well, but let's see how it goes later in the year. So thank you very much.
Thank you, Daniel. Really, really interesting and quite bold is fair to say is kind of pertinent to the context for Luft and some of the performance issues that you're looking at. So really interesting, thank you. Colleagues, just a reminder, if you want to place questions in the Q&A app, you can do that and we'll pick them up in a moment's time. But now, very pleased to hand over to Brian for his perspective.
Thanks very much, Miriam, and good afternoon, everyone. As Miriam said in her introduction, I am currently Chair of Audit and Risk at Avon and Wiltshire Mental Health Trust, or AWP. Prior to that, I had 9 years at the Royal United Hospitals Foundation Trust in Bath, and we were a foundation trust there for the last 5 years. So I've been able to have experience of a couple of different systems, both FT and non-FT, and also acute and currently mental health. I'm just going to share a couple of experiences I've had in terms of structure, and then I'll go slightly wider into some personal thoughts on governance and just try and share a few of the things that have worked for me. So if I can move on to the first slide, please. Thank you. So this is my time at the Acute Hospital Trust, which we developed this over the years that I was there. Both of the structures I'm going to share this afternoon come from my view that you can't do all aspects of governance at a board in order to get to that level of constructive challenge that we're particularly tasked with as non-executive directors. I think to get that granularity, you need to do it at a slightly lower level. So 2 structures where that's worked for me. At the Acute Trust, 3 assurance committees, pretty much what they say: clinical governance, which covered all the incident management, reporting, quality of care, patient safety, patient experience, compliance in terms of particularly CQC and NHS resolution, also picked up issues of research and development. Non-clinical governance, pretty much everything else, mainly picking up performance management, workforce, aspects of equality, diversity, health and safety. And then audit and risk, giving that overview of assurance to the board that the assurance frameworks are effective and that the trust had good control over risk, good sight of a corporate risk register, board assurance framework, as well as covering the statutory requirements of internal and external audit and counter fraud. What we tried to do there in order to bring a level of continuity when reporting through to the board was to have the chairs of clinical and non-clinical gov assurance committees sat on audit committee to make sure nothing dropped down between the stools. And we also made sure that full meeting minutes were sent to the board meetings, and we used to get the non-exec chairs of the assurance committees introduce their papers and then would encourage to have that challenge and questioning from the whole board at that particular board meeting. If we go to the next slide, this is what we've currently evolved into at the Mental Health Trust. So similar structure, but slightly different ways of putting this all together. So we have an audit and risk committee, quality and standards, which is similar to clinical in acute, but obviously we cover quite a lot of other service delivery areas in a mental health trust. Finance and planning, I didn't have that in the foundation trust. We do have that in the mental health trust. And then the 4th assurance committee covers delivery and workforce. So audit and risk very much has the overseeing remit. Again, it covers internal, external audit and local counter fraud. It really seeks assurance that we have effective systems of accountability and internal control, has the responsibility for the corporate risk register overview and recommendation of board assurance framework risks into the board itself. And obviously statutorily, we look at the annual financial statements. And now following the guidance from NHS EI a few weeks ago, we've now got oversight for security management, procurement and cyber security. The corporate risk register is now involved into a document where risks rating over 15 on the 5x5 matrix now come through audit and risk. They are assigned so that every corporate risk over 15, and currently I think at AWP we've got about 24 of those, They have an exec owner who is responsible for overseeing the delivery, and they have a nominated assurance committee that is responsible for giving the wider assurance. And audit and risk will have 2 or 3 of those corporate risks will be assigned to us. The other ones, we will seek assurance from the other committees that they have capable processes that will lead to better outputs as part of the assurance program. I won't go through the detail of the slide, but you can see the areas of what quality standards, finance planning, and delivery and workforce pick up. The only difference in reporting is that in this one, the chairs present the chair's summary of the assurance committee into board. Not always the best way of doing it. I prefer personally that minutes go, but it works for AWP. So the chairs produce the report and the summary goes in, but of course, full minutes are available should anyone want to look at them in more detail. So that's a little bit about the 2 structures that we've had experience of and evolved into these structures over a number of years. If I can move to the next slide, just to give you some of my mainly personal thoughts of some of these wider aspects. I believe that you can't undertake all aspects of good governance and assurance at a trust board meeting. And I'm also very conscious that structure is only a very small part of governance. So governance is very much about the people and the way the organisation approaches it, rather than just the structures that are actually set up. I look particularly now as chair of audit to look for 3 levels of assurance. What I call the first level is reassurance. That's what we're told. And if we believe that or assurance or not, very much depends on the experience that we have with the individual telling us. At the next level of assurance, we can actually see what we can go out and check, and then we can get some assurance from what we see from NED visits. We have 3 visits sitting on, 3 NEDs sitting on the audit committee. They go out, see what's happening, we can find out what's going on. So the second level of assurance is what we've seen or what we've seen other people are assured about. And then the third level of assurance we've got, which is the independent source, which could come through from focused internal audit reports, or it could come from feedback from the CQC. We also had this active use, something we pioneered at Audit and Risk at AWP, this assurance mapping. So we map all of the CQC domains, and we ask internal audit to keep a log of which committee is doing what. So at the first level, we'd have the operating functions mainly led by execs on the next level down. So that's the operational side. Then we've got a series of oversight committees, again, primarily working at management and executive level. And then we've got the independent functions, which are all pulled together at audit committee, which link in either CCG visits and inspections or CQC, or we can focus internal audit. So the assurance map gives us the ability at audit committee to have that visibility of where our assurance is coming from at all 3 levels. So reporting to board we've talked on. Good practice works 2 ways. Committee chairs can either highlight key items trying to promote board discussion, which works, or we can have full minutes. Both of those can work. We use a standard way of reporting from all of the committees up to the board at AWP. So all agenda items are given an assurance rating. That could be from no assurance up through to significant insurance. We use SBAR reporting, that's situation, background, assessment and recommendation. So that's standardized across all of the committees. So at least we get some consistency across there. We have a structured cross-committee referral system. Not only do we have NED sitting on 2 committees, but we also have a list looked after by the company secretary to make sure that goes through. And we also have annual reviews of committee efficiency and effectiveness, which are absolutely critical. And then if you're chairing a assurance committee, ask yourself, how many times have you changed as a result of doing an effectiveness review? And finally, if we can move to the last slide, just some personal thoughts about it. for these committees to work effectively, I think the relationship between the non-executive chair and the executive lead is essential. For example, I meet, as I'm sure audit committee chairs do, on a regular basis with our Director of Finance. We agree a work plan, we agree the agendas, and we have a regular meeting just to make sure that everything is available and ready for meeting in plenty of time. Focused agendas, discrete meeting lengths. I found after chairing a foundation trust that any meeting longer than 2 hours, certainly the people I was chairing used to get bored, so do I. So we have very focused meetings. We don't like long papers unless we have to. Also, on a practical note, I found that NED chairs can be tempted to set meetings at non-executive director convenience. I think as non-execs, we should be fully aware of the workload of our executives and key members. And it's a critical one for me that if we really want these committees to be effective, we need to set times where the NEDs can be there at a convenient time for executive and key members. Friday afternoons don't work. Ideally, we should rotate chairs from time to time to avoid stagnation, but it's critical that we appoint NED chairs that are interested in their particular areas. And of course, we can't do that easily in audit and risk because it needs to be a qualified accountant. I've talked about sharing annual reviews of effectiveness. I've talked about cross-functional committee membership. I've talked about this idea of corporate risks being identified to an assurance committee. I think that works quite nicely in our particular structure because it means that every corporate risk has not only got an exec sponsor, but it's got a process and a program where outcomes are actually checked in terms of assurance by one of the oversight and assurance committees. And the final thing to add from experience of both trusts that I work for, having regular meetings with the non-executive directors on the committee works well. And I think it's also good that non-execs meet together as a wider team to discuss how the committee assurance process is working so that can feed back up into board meetings. So that's all I wanted to share. Thank you very much for the opportunity. Miriam, I'll hand back to you. Thank you.
Brilliant. Thank you, Brian. It's a really rich presentation, so fantastic. So we have got a number of questions that are coming through. Thanks, colleagues. Keep adding them to the app. So what I'm going to do is I'm going to try and start from the more practical, technical, and sort of work up to questions around risk management and scrutiny and challenge. So if we start with, let's start with a question from Paul Howard. Thank you, Paul. And I'll come to Brian first and then Daniel. Could you say a few words on who you have in attendance at committee meetings? So do you have a large number of attendees or do you keep it quite tight to the core membership committee? And if I could just add to that a sub question around your views on when and if it's appropriate for governors to attend committees, similarly colleagues from the organisation. Brian,
okay.
Would you comment on that first? Thanks.
Yeah, sure. Thanks for the question, Paul. Yeah, let me take the one that I know best of so far, which is audit and risk. So obviously we have internal and external audit there. As part of our wider brief to get assurance on corporate risk, we will have one of the operating leads for the 3 main divisions that we have coming through and rotating. So audit committee meets every 2.5 months. We'll have a divisional lead come in and present their particular aspect on the divisional risk register so we can just see how risks work up from the ward through to the division and then how they get onto the corporate risk register. We'll also have a couple of people from the corporate governance team there. I usually have about 3 non-executive directors, but what I try to do for the meetings that I chair is only have the people in the meeting that add value. So we'll bring in a divisional lead for that particular part. Usually it's the first half hour of the meeting. Any people that are not regular members of the committee, I will have them come in for the first half hour so they're not hanging around just out of courtesy. We look at security management, for example. We look at procurement. So we'll get a feedback report for those coming into audit and risk. And again, we'll just bring them in for the specific item. They're welcome to stay. But we'll just bring them in for the specific items. So we're using their time effectively. And I know certainly at the Quality and Planning Committee, which has a far wider remit, and they again will have a core membership. Always the Director of Nursing is there, always the Medical Director is, and then there'll be a number of people coming in that will depend on the agenda items. But again, that'll be time, so they're just coming in for the focused part of the meeting. In terms of governors at committee meetings, had a number of iterations of this when I was chairing a foundation trust, and this is very much a personal view. We tried to have non-execs coming into Council of Governors meeting to report back on what was done in their committees. That worked reasonably well for a couple of years. But for the last 2 or 3 years when I was at Royal United Hospital, we had governor observers at committee meetings, purely so the governors could see how the NEDs were discharging their functions in terms of assurance. We made it absolutely clear that those governors were only in as observers. They didn't contribute to the meeting. They were just there to build up the picture they had of the effectiveness of the NEDs in their challenging role as part of the unitary board.
Thanks, Brian. And Daniel, any perspective on that?
I'll start with the second one first, if I can, about governors. In terms of governors, we've kept in line with the previous blogs issued by NHS providers, which is to say no. I think what it does from my point of view, it blurs the boundaries of accountability and responsibility between the governor and the NED. We've looked at other ways in which governors can view the work undertaken by NEDs, and they can do that at the board of directors. Our visiting programme is jointly between NEDs and governors, and similar to what Brian said, we also have most of our NEDs attend the Council of Governors when it meets on a quarterly basis, and they provide updates on the work that's going on in the committees, and they're open to questions from the governors in that place. But we've kept in line with the previous blogs issued by NHS providers. In terms of the committees, we really only have one main committee, and that's the Audit Committee. So we have basically all NEDs sit on the Audit Committee. The only one who's not a member is the chair. And we have actually attendance by all executive directors as well at the Audit Committee. In terms of the others, when I talked about the Executive Assurance and Risk Committee that's chaired by the Chief Executive, we have attendance by all of the executive directors, and from our leadership teams, we have leadership teams across 3 hospital sites, our laboratory services and key corporate services such as people and OD, and also estates and facilities, and they're the ones who sit round the table.
Really helpful, thanks. I think it's a judgment call on those observers, isn't it, depending where your relationships are at. So great information, thank you. So we'll move on to a question from Sarah Anderson about committee minutes. If you're sending committee minutes to the board, how are these confirmed? Do you send unapproved minutes or minutes that have been agreed by the committee, which means they could then prove untimely? In Sarah's trust, they do a written committee chair report to the board. So I think it's a question on how you get that kind of timely flow of information from the committee to the board. I'll come back to Brian again first, thanks.
If I use the current system where we have chairs, summaries that go into the board, we have 2 ways of doing that. If the written report from the chair doesn't have time to get to the board meeting, then the chair will give a verbal update and then the words will follow later. What I used to do at the previous trust is that we used to actually time the clinical, non-clinical governance and audit risk so that the minutes could be approved by the members of the committee before they went to the board, so nothing was too late. We tried to keep the spontaneity. So the assurance committees would meet every 2 months, and then they would link in the meeting. So there was a couple of weeks before the meeting to finalise, agree the minutes, so that the minutes going to the board were never too particularly old.
Thanks, Brian. Daniel?
From our committees, we don't send the minutes to the board of our audit new hospital. We have a chair's report that would go to the board, and what that's focusing on is focusing on mainly any issues that the chair of that committee wishes to escalate to the board and bring to the attention. And that can be items of risk, or it could be items of good practice that they want the board to recognise. We've tried to time our meetings so that the cycle happens all prior to the board. We tend to have our audit committee literally within a few days before the board. That tends to be a verbal update, but one of the things that we've started to do is type a very quick risk summary within a 24-hour period so that we can circulate that to board members so they can see the key issues of risk. But we don't send the minutes, but all board members can see papers of all of our groups and the minutes of all groups on our virtual board portal.
Thank you, really helpful. Couple of questions here, I think mainly for Daniel, if I may. So first one, more practical from Susan Juve. How long typically do your bi-monthly board meetings last? How many agenda items and how many pages in the pack? And a second one for you, Daniel, to think about. Question from Pauline Lambert. How does NED scrutiny occur on those groups that are chaired by an executive? So a couple for you there.
Okay, number of papers is quite easy because I counted them last week for our board meeting. I think the number of agenda items just fluctuates at the board, but I think last week's board, if I remember rightly, we split the packs into two, similar to a number of organisations. I think our board pack was about 110 pages, and that included the integrated performance report and also the quarterly board assurance framework. But we then supplement that with an information pack, and the information pack had 126 pages. One of the things that we encourage is say to board members, the main pack is the key set of documents that you need to read. They should be the ones that highlight risks, highlight the key issues and areas to focus. The information pack is our appendices, which means you should be able to still have that discussion based on the core pack, but supplementary information is available for your site with the second information pack. Scrutiny happens in many different ways. I suppose the question that what we've asked ourselves is, NEDs can see papers to any of our executive groups that take place. So they can see all of the papers that go to those executive groups are available for them. If they wish to attend, they can attend, but they're not members. They've chosen not to attend, apart from our research group where we have one NED who does attend. They undertake their scrutiny basically through the audit committee, and the audit committee, we have a series of deep dives into the most significant risks or risks that the NEDs wish to discuss. So our last audit committee, which was last week, I think we looked at 12 different risks at the audit committee. We had, when I say deep dives in board discussion is probably anything more than 10 minutes. So it was sort of a 10-minute discussion where they sought assurance, evidence, and wanted to know the plan of action to reduce the level of risk and by when and how will they know. But they supplement that with visits to services from discussions and through, as Brian said, through a triangulation such as internal audit and external reports as well.
Thank you, really helpful. Okay, one for both of you now, I think, for your thoughts. From Helen Board, recommendation from a recently completed external well-led developmental review was to only include NEDs as voting members on committees of the board. The Trust currently has NEDs as a majority with execs in the minority. So thoughts on who should have voting rights on board committees? It's like a governance test, isn't it? But Brian, do you want to come back on that one?
Yes, I'm not a governance expert like Daniel is. I'm going to hedge the question slightly because I'm more interested as chair of an assurance committee. I very seldom have a vote. I think I only had one vote of the board when I was chairing the RUHFT, and that was on whether we were going to become a smoking site or not. I think I'm more interested in how the individual viewpoints are actually known. So whether an exec or a non-exec is in the majority voting, I really don't mind. I'm more interested in the debate and the conclusion and how we get our assurance. I mean, in the board, it's quite clear non-execs are in the minority. So, sorry, in the majority, execs in the minority. If we have the same in meetings, I would expect that to be reflected. But for me, the key is about the content rather than actually the way of structuring who has voting rights and who not.
Thank you. Daniel?
So, thanks, Helen, for the question, and probably similar to Brian. I'd probably question, if you're questioning who's voting and there's too many issues about voting, non-voting, it may raise some different questions about how is your board or your committees operating. I think over the years, the last couple of years, I've seen very few votes happen. The only votes that I can recall recently probably came from doing something formal when it came to a merger and acquisition in a previous organisation. I think if you're, but I did go through a time in one organisation where literally every paper was voted upon. But that told me quite a lot about the disconnect between the non-execs and the executives and the lack of the focus on a unitary board. Because we only, ours is slightly simpler because we tend to only have the audit committee, which is only NEDs and members of the audit committee. So that makes that one simpler. On our new hospital committee, we have, again, all of our NEDs are invited to that, and they're all members. So we don't tend to have, we've never needed to use a vote. So I would probably look back on that. I mean, I suppose one of the questions that I say on the external well-led reviews is, what was the problem they were trying, what was the actual problem that they had identified where that issue was actually raised? And to try and see, is it about voting, or is it about the need for some further development within the board about how you define the role of a unitary board and how you work together?
Thank you. There are quite a lot of questions in the chat, so colleagues, I'm mindful of time. I'm going to have to be selective, I'm afraid, but perhaps we can share Brian and Daniel's contact details if there are further specifics that you want to follow up with them on. So I'm going to come to a question from Kathy Lilly, which strikes at the heart of all we do. How do you balance governance and assurance at board committees and ensure the service user patient voice remains at the heart of what we do? Brian, do you want to come to you on that one first?
Yes, it's something that we're very conscious of, even more so, I think, at a mental health trust than we have been when I was at the Acute Trust. We did pioneer back in 2010, I think it was, patient stories at board, because I think it's very important that they come at the top level, not just at committee level. Certainly, we followed that through at AWP. Delighted that we still have, even in these virtual times, we have patient and or staff stories to all of the board meetings, which is critical for me. One of the advantages of somewhere like a quality and standards committee is that you can bring in service users, and we have a whole raft of people at AWP that we call experts by experience, and these are primarily service users that can actually come in, and they are welcome to contribute to some of the work at committee level, but again, very much at a focus level. So they will be invited in to give us a level of assurance at particular detail. But for me, again, the main level is having service user stories at board as well.
So important. And Daniel, I'll come to you briefly before I wrap up.
So very, very similar. We have both we try and mix it between patient and staff stories. So it's important to actually get a flavour of what's going on within the organisation. We try and mix it between good and bad stories. And also within our hospital leadership teams, we've encouraged them to actually mirror the same arrangements so that they're hearing from patients directly who reflect the services that they provide. But vital that you keep that connectivity, otherwise your board will work in isolation of what the services are actually being felt like by your patient groups.
Thank you. Well, colleagues, thank you. We could have continued this discussion for so much longer, so we'll make sure you've got Daniel and Brian's contact details for those outstanding questions. But huge thank you to both of our speakers today. I think for me, two very different approaches from trusts, perhaps in different places with different contexts, but a very common commitment to ensuring appropriate challenge and to managing risk effectively on behalf of the patients and service users that we're serving. So thank you both, Daniel and Brian, for giving us your time, really helpful, rich presentations, and thank you everybody for your questions. Hope you enjoy the rest of the day. Thanks ever so much.